This is the Pallium Podcast, a production of pallium.org at the intersection of palliative and emergency medicine. I'm your host, Justin Bruton. Today I'm joined by Dr. Mariana Murea. Dr. Murea is an associate professor and a practicing nephrologist and clinical investigator at the Wake Forest School of Medicine in Winston-Salem, North Carolina. She is a recipient of NIH-funded awards and the Mid-Career Clinical Investigator Award at the Wake Forest School of Medicine. Her research has focused on addressing gaps in the care of patients with ESKD on hemodialysis, with an emphasis on patient-centric care. She is dual board certified in both internal medicine and nephrology. Dr. Murea, thank you so much for joining me today.
Thank you very much for the invitation. It's an honor for me to talk about patient-centered care in individuals who need hemodialysis.
So one of the things that I've appreciated in talking with you previously is how you've been able to take a field that a lot of people don't think of as trying to marry patient-centered care with the kind of things we do to extend life, and you found a way to do that. So as a nephrologist, to what extent have you found palliative care to be important in the management of end-stage kidney disease? That's a great question. And end-stage kidney disease is unfortunately life-limiting, incurable illness as of now. Nevertheless, it is an illness that can be treated with some of the most revolutionary means ever developed in medical science, which are dialysis and kidney transplantation. But this means that patients with end-stage kidney disease on dialysis live with a burdensome condition, and they often have many other comorbid illnesses. So having end-stage kidney disease means that patients inherently suffer from a plethora of symptoms that generally tend to grow in intensity with time unless the patient is eligible and can receives a kidney transplant. So these perennial symptoms include fatigue, insomnia, pain, itching, poor appetite, and so on. And palliative care, as we know, focuses on symptom management and goals of care reassessment with a focus on quality of life. When traditional treatments do not offer sufficient symptom relief, and are not expected to add appreciable quantity of life without further deteriorating the quality of life, right? So sometimes in the trajectory of end-stage kidney disease, a moment comes when treatment with full intensity dialysis, let's say 3 times a week hemodialysis, 3.5 to 4 hours per each session, is no longer in the best interest for the individual who enters the end-of-life stage. And that is the point where one could consider decreasing the intensity of hemodialysis by either having less frequent hemodialysis treatments or shorter dialysis treatments. And this form of decremental hemodialysis for the purpose of palliative care and transition into end-of-life moments is focused on quality of life than biochemical targets. And so to answer to your question, palliative care is, I would say, a requisite component of a holistic system of care for end-stage kidney disease that can offer an adaptive dialysis treatments according to different stages and different needs of each individual on dialysis. That's excellent. I like how you talked about adjusting treatment to fit the needs of the patient and thinking about that, the weighing the biomedical markers we use with the needs of the patient and trying to think about their quality of life and trying to balance both of those things. It's a dynamic process. So how do you find that the needs for palliative care are addressed in patients with end-stage renal disease?
Well, so and in a real world, each dialysis unit would have a palliative medicine specialist, right, that works in concert with the nephrologist and the dialysis personnel. And by that, I'm referring to dialysis nurses, dietitians, and social workers. And as a group, this interdisciplinary dialysis team and palliative care team would address and adapt dialysis and medical treatment plans corresponding to the stage of illness for each individual with end-stage kidney disease. But
in real world, it comes down to the nephrologists themselves to employ medications for treatment of insomnia, itching pain, tend to the patient's psychological needs, and initiate end-of-life discussions and offer palliative dialysis in proper scenarios. But with the current model of care that is rather metric-driven, high-paced, volume of care rewarding, there is a gap still in the way kidney palliative care is practiced in the community.
Yeah, it sounds like you've had to employ those techniques that you've picked up just to make sure that those needs get met.
Yes, and I think they should be employed a lot more often than I admit I am doing. That our patients, we have to remember though that even if when I need help, I'm referring the patient to palliative care clinics. It's very difficult for them to actually go to those appointments because they deal with so many other, schedules and appointments and dialysis itself, that often we are left, sort of seeing by ourselves as practicing nephrologists to try to meet all these dynamic and complex needs.
That's an excellent point. They already have so much contact with the medical field already because of dialysis itself and because of their other medical visits. So you're right. Trying to get them to fit another appointment in their schedule is pretty difficult.
Yeah, and there are only 5 days in a week, right? And for many of them, 3 days are already, occupied with dialysis, and the other 2 are, kind of at least to live some of their life. But
I imagine this is the case with other services that they need, but because of how much time they spend in dialysis, whenever those things can be bundled in to the care they're already getting or concurrent with that process, it makes a lot of sense. So dialysis is not typically associated with palliative care, but you have patients on dialysis that are closer to the end of life, and you figured out how to incorporate a palliative care approach at the same time as managing their dialysis. Can you tell us more about that?
Yeah, so, there are certain clinical contexts in which I offer palliative dialysis or even dialysis withdrawal. And for example, patients with an estimated life expectancy of less than 6 months or are irreversibly bedridden and have frequent hospitalizations and are on perhaps other mechanical support, or who have severe cognitive deficits and are very, very frail. So in these situations, I meet with patients' families and caregivers, and I initiate end-of-life discussions and plans, and I discuss the pros and cons of palliative dialysis. Because with palliative dialysis, the treatment goal, again, it's aimed at quality of life rather than medical parameters. And so in the case of in-center hemodialysis, I discuss adjusting their or dialing down, right, the treatments to either twice a week or still 3 times a week, but shorter sessions like 2.5 hours or 3.5 hours per dialysis treatment. But I want to emphasize that there is no single formula for palliative decremental dialysis. End-of-life discussions are a long process, and end-of-life decisions are very complex. And at the end of that process, the direction may be towards decremental palliative dialysis and then dialysis withdrawal, or proceed directly to dialysis withdrawal, or even maintain fully intensity dialysis. And sometimes the first decision is, or the first conclusion that is drawn after an end-of-life discussion and meeting is not the last decision. So revisiting goals of care should always be kept in mind when deemed appropriate.
That's so true. It's not you mentioned that before. You said ongoing goals of care, and that's one of the things about palliative care. It's not a static process. Their comorbidities change, their treatment burden changes, the other things they're dealing with changes. So the target moves, and that's very true.
Right. Yeah, patients and caregivers go through different coping mechanisms, and for some people, obviously requires more time to kind of digest or adjust to the idea that things are moving to a point where medicine has reached its limits. Yeah.
And I think dialysis, probably because it's just become such a routine part of somebody's life in many cases, that's such a big decision to transition off of.
Right. And that's because, when we start dialysis, rightfully so, we say that, you reached a point, you meaning the individual afflicted with end-stage kidney disease, reached a point where without dialysis, death is imminent. So for them now to come and say, we reached a point where even with dialysis, we're getting there, and which is just becoming more and more maybe burdensome for everybody, just to see how difficult they tolerate dialysis. So yes, I think for some people it's they have obviously a lot of emotional turbulence when they hear that. Other people just welcome that discussion with a big sense of relief. And in other people, it's anywhere in between, and they require or they want to have, further thoughts about that.
You've mentioned a bunch of the different techniques you've had to use to try to address the palliative care needs in your patients, especially since they already have so much contact with the medical system. You really need to provide a lot of that care yourself. What are some of the things that nephrologists learn in training about palliative care, or is there much that they learn about palliative care?
Yeah, that's an excellent point. So, for example, when I trained, my fellowship did not have a nephrology palliative care curriculum, but that's because the attention to palliative care in nephrology in patients with kidney disease and patients on dialysis has grown exponentially just in the past few years. So these days, more and more institutions, academic institutions, have a nephrology palliative care curriculum integrated within their the whole kind of nephrology education that we provide to our fellows. And also on the website at the American Society of Nephrology and many of the national and international nephrology meetings, there is more and more talk and kind of organized, structured, didactic sessions on palliative care. So I entered the practice of palliative dialysis and palliative care in patients with kidney disease without necessarily a formal education, but just by listening to the patients, feeling for their needs, and obviously reading and talking with other people, going to conferences, and listening to webinars. It's a skill that grows on you, and it's very compassionate, and it's something that our patients definitely need. And I think there will be more and more, even dialysis systems or networks that will start probably offering palliative care on a more routine basis, and such a setup is already in some parts of the country, but it's still kind of a big gap out there.
Well, it's good to hear that that's an option that's starting to become available, even if it's really limited at this point. It sounds like there's people like you that are advocating for that, which is a good thing. So one of the things that's really fascinating to me is thinking about dialysis as a means of comfort measure, and how does it function like that for some of your patients that are on palliative dialysis, and how does that work exactly?
Yeah, so in my experience, palliative decremental dialysis always fulfilled its anticipated role of comfort and end-of-life transition when I deemed that approach would be useful. And very often I observed that patients and caregivers had this sense of lifting a burden off their shoulder. And it was a sense of, wow, I don't have to come to dialysis 3 times a week when I feel so sick all the time, or, kind of I know that, I have the end is coming, and that's okay if I don't come because the doctor says so. So it's a big, big sense of relief, lifting off burden, a big burden from their mindset. And then not only that, it basically gives them more time to cope with the end of life symptoms, or time to spend with their loved ones. But it also it's kind of used. I see it as a very compassionate way of transitioning to dialysis withdrawal and hospice. So for some patients, it's difficult to let it go all of nothing, just from a day to another. So it's they have welcomed that kind of option of let's try to do a little bit less intense sessions. But I also want to mention, so these are the advantages of the palliative decremental dialysis there, but there could be some drawbacks when we think about palliative decremental dialysis, and this have to be outlined and considered during a palliative treatment plan for these patients. And what I'm referring to is the possibility of developing volume overload in patients that are dialyzed less frequently. So by all means, we don't want to induce a prolonged suffering or more suffering to these patients. So I'm offering generally palliative dialysis to those who have very small gains, fluid gains between dialysis treatments. And that's often the case in patients who are near end of life because they don't have a lot of nutritional intake, unfortunately. And I also discuss with my patients and their caregivers the goal of staying out of the hospital, since the aims of palliative dialysis is for the patient to spend more time with their loved ones and have less intrusive procedures, right? So I often have this no further hospitalizations agreement declared between the patient caregivers, myself as a provider, as the dialysis staff, and even the nursing home personnel as applicable. And that, I find it is very considerate of, the patients, the family, and all the resources that are available.
That's really, this is so interesting. I love hearing about this because it's what you said. You said several things there that I think are excellent. One, the idea that just abruptly stopping is a really, really tall cognitive barrier to overcome for a lot of people. So I think the idea of kind of graduated decremental, you said, decremental dialysis, I think that's brilliant because it gives them that chance to kind of enjoy the benefits of the extra time. And like you said, the ones who are closer to end of life anyways, they're probably not, having lots of fluid gain. So it makes a little more sense anyways. It's more feasible. And I think you're right. It gives them some time to process. It gives them some time to think about the care transition, which I think is a big deal. And it actually reminds me in some ways of when we have people in the hospital and they've had multiple hospitalizations. It could be something totally different. It could be, somebody with dementia that keeps getting recurrent infections. And sometimes the family wants that last try of doing antibiotics or something, and they may come to the conclusion, okay, the next time we won't do them anymore. But that last hospitalization or two, they have a chance to sort of do some limited treatments and kind of see how they do. And it doesn't feel like just this abrupt transition. They kind of get a chance to sort of slowly transition the care goals as opposed to some abrupt change. And I think just in human nature, it just makes more sense. People are going to have an easier time with that. So I think that's really brilliant. And the other thing that highlights what you said is it's really tailored to the patient and the family. Not going back to, let's make sure you don't want to go back to the hospital because the goal here is not to completely medically optimize you, but it's to improve your quality of life. So those negotiation plans, they take more time to do that. It takes a lot more time. but it's patient and family centered. Tell me about that. I think that's really, it's beautiful. The word that kept coming to my mind as you were talking about this, you said compassion, and I think it is. It's kind of beautiful, when you make a plan that says, I'm going to think about you as an individual and how to help get you through this the best we can. Tell me more about that.
Yes, I mean, it's to offer patient-centered care obviously requires a lot more time at any level and in any medical field. And particularly also, actually, even more so, I should say, when it comes to end-of-life discussions. And, having to weigh all these different aspects of what is end-of-life going to look like, yes, and doing this form of palliative dialysis, which is part of, as we said, a form of the mechanism of coping with end of life. But it's, at the same time, you're gonna get sicker. So I'm preemptively trying to show them that this is how it's going to look. I mean, we were trying to keep symptoms at bay as much as possible, but it's things will still regardless get worse. And I find that social workers at the dialysis unit are extremely helpful. Nurses are very, very critical also to be part of that meeting, not only the social worker, but also the nurses, because they see a lot more often than we as doctors see them on dialysis and how much they suffer. And, hearing, kind of the impressions and the heartfelt advice from all the members of the dialysis team is a very good tool. Maybe I shouldn't say tool. It's something that actually family members or caregivers and patients do appreciate and want to see. It's kind of, we all care about them, and it's not that we don't want to offer dialysis anymore, but at the same time, they do get sicker and they go to the hospital and come out and they are in the same condition at best, but usually worse. And, it's just a cycle of worse and worse and worse. And, so it is time-consuming, but it's very rewarding to know that, especially when you see how appreciative the family members and caregivers and the patients are to open that discussion many times. Yeah.
Yeah, that's awesome. I imagine too, especially just because you have long-term relationships with these patients and these families, it's just such a kind of a meaningful experience, painful, I'm sure, but really meaningful to be able to help them with that transition.
Yeah.
One of the questions I have too is, as wonderful as all of the work you're doing in patient-centered care is, what are some of the obstacles that you face in trying to initiate and conduct palliative dialysis in patients with end-stage kidney disease?
So, indeed, it's, as I said, there is a critical gap, a large gap in the employment of palliative care in patients with advanced kidney disease and on dialysis. And there are many reasons for this, but I will probably try to mention just a few. For example, first and foremost, I would say that the research and the knowledge on palliative dialysis has been very scarce, and the incorporation of palliative care curriculum within nephrology specialty curriculum and fellowship training, although has been growing, is not uniformly present across academic centers. So many nephrologists who are finish their training don't feel as comfortable in having these discussions or recognizing when it's probably time to start having some early discussions around that end of life plans. And then there's also the issue of dialysis unit operationalization because in order to accommodate varied dialysis schedules is a challenge because it creates a string of administrative needs that must be fit all of them into an efficient workflows and properly staffed units, right? Not overstaffed or understaffed either. And then there is, of course, the aspect of metrics-driven dialysis care and treatment-based reimbursement. And palliative dialysis and less frequent dialysis treatments would inevitably interfere with this aspect by causing, larger deviations from metric targets such as phosphorus levels or calcium level or intact PTH level, who, frankly, in that subgroup of population, it becomes meaningless, but yet, it goes on the metrics and, as well as fewer dialysis treatments. So with all this being said, though, there is more and more optimism than ever, as I said, that, patient-centric care in end-stage kidney disease and patients who need dialysis is receiving more and more attention in the field of nephrology.
Yeah, that's good to hear. It seems like there's a lot of tall obstacles to still be navigated. And I wonder, too, even just things like insurance policy and, the way metrics are analyzed, if you have a subcategory that kind of keeps those patients from getting the nephrologist penalized for trying to do the right thing, if they're not on the same dialysis plan, that would be helpful. But that doesn't exist yet.
Yes, exactly. So I think obviously, kind of in the metrics-driven system and, kind of policies, that underlie all of this practice to a certain extent, will need to be reformed, right? All the policies and, the way care is evaluated, patient care is evaluated way beyond the metrics. But it will be very complex to, as we know, to evaluate quality of care is very difficult. Now, and I'm not talking only about dialysis, I'm talking about, just across all specialties and all these elements that I also mentioned, more research and better education, all intertwined. You can have, even if you had, policies, or I should say policies don't change unless you have good evidence. And once you have good evidence, then, you need sufficient training and implementation. So, such a change is not going to obviously happen overnight, but we will get there, I'm sure.
Well, I've really enjoyed listening to your responses and what you're doing to try to address the needs for this patient population that I think could get overlooked easily, and the needs that they have that need to be addressed in kind of novel and creative ways. So I really appreciate that, and thank you so much for joining me today.
Thank you so much for the invitation. Thank you for having me. Thank you.
For more information on current topics in the fields of palliative and emergency medicine, please visit palliam.org.